Madam, we are live now. Madam, shall we start?
Yeah, we can start.
So good evening, doctors and all the participants. Shuman on behalf of Shield Healthcare, welcoming you all in today's session on menopause and its treatment in perspective. And our guest speaker is Dr. Jasmeet Dhingra, madam. Now it's time to introduce our Shield Connect, that is our knowledge sharing platform. That here you can find different blogs written by many eminent doctors across India in different topics. And these are the past webinars already we have conducted in our platform from the various parts of the country and in many topics as well. And the most important thing is the awareness tabs. Here you can find all the related topics in our different tabs. And the important ones is our key opinion leaders. So presently, more than 500 doctors are currently supporting us, our knowledge sharing initiative of Shield Healthcare. So it's a very important website in terms of our subject area itself. Now it's time to start the session with Madam, and it's my honor to introduce Madam. Madam did her MBBS, MS Gold Medalist, and Madam is the consultant obstetrician and gynecologist in Agra. So with this short introduction, I request Madam to take over the session. And meanwhile, I request all the participants for your active participation. And please post your queries of the QA dashboard of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this topic with Madam. So thank you very much, Madam, and over to you.
Yeah, good evening, everyone. So my big thanks to Shield Connect so that you have given me this chance. And today we'll be talking about a very interesting topic, that is menopause and its treatment. So shall we start, or we should wait for some participants to join?
Madam, it's a speaker link only. Participants link is other link. So you can start.
Okay. Is it visible?
No, Madam.
Not yet, ma'am.
Not yet?
No, ma'am. Screen share.
Yeah, I've done it. I'll do it again.
Yes, Madam, it's visible.
Yes.
Yeah, it's fine.
Today we'll be discussing a topic that is menopause and its treatment. So first of all, what is the menopause? Menopause is a normal natural event, that is a final menstrual period that gets over, and that is defined as if there is no menstrual bleeding for more than 1 year. It represents the permanent cessation of menses resulting from the loss of ovarian failure. The normal average age of menopause in India is 46.2 years. And if we look at the Western countries, the average age of menopause is 51 years. That is very much as compared to India. So there can be a premature menopause due to medical intervention. The causes may be bilateral oophorectomy or chemotherapy. There is one condition called premature ovarian failure or insufficiency that we'll talk later on. So, what's the physiology of the menopause? So, each ovary has a certain number of oocytes from the birth, which steadily decreases when your age increases. So, at the age of 46 around, our oocyte reserve is already diminished. During the perimenopause follicular activity phase, the estrogen level decrease and the pituitary gland, it produces more amount of LH and FSH due to a negative feedback. Cycles become anovulatory, follicular development stops, the endometrium is no longer stimulated, and hence the amenorrhea is there. So, no menstrual cycles occur, and the patient has a menopause phase. So, we already know it's a straw staging which determines the menopause. It's divided into many categories, that is reproductive, then menopause transition, and finally the menopause. So the -2 and the -1 stage is for the menopause transition. The -2 is when you have two consecutive menstrual cycles with more than 7 days of increased cycle length. And -1 denotes when you have no period or there is a amenorrhea of more than 60 days. So the stage 1 and stage +1 and +2 that determines that there is no menstrual cycle, the patient is already land up into menopause phase. So the hormones here varies. The FSH is increased and the AMH level is at the lower side. So the age of the menopause has remained constant while the life expectancy has increased. So I already told you the average age in India for the menopause is 46.2 years. It has remained stable for so many years. So, what are the hormones that are affected at the menopause? The circulating estrogens, they are decreased level of ratio of estrogen to androgen. The sex hormone binding globulin secretion is decreased. In return of that, with the negative feedback, there is peripheral aromatization of DHA to estrogen, reversal of E2 to estrone ratio, and there's no significant change in testosterone levels. So, where are the estrogen receptors located in the body? So, the estrogen receptor is a group of protein that is present inside the cells. They are activated by the estrogen hormone. So, the estrogen receptors are found in various parts of the body. Their receptors are divided into two categories, that is alpha and beta receptor. So the alpha receptors, they are found in the blood vessels, bone, heart, breast, ovaries, testes, and prostate in males. The beta receptor, it is present in lungs, kidney, bladder, intestine. So the all these receptors, they have different categories. Into proteometics, we will not go now. So this is the effect of estrogen that do various functions at the various sites of the body. See if the estrogen is present, so it increase the bone density, and if it is diminished, it will lead to the osteoporosis in a female in menopause. On brains, when it is present, it will release the ovarian estrogen. And if it is absent, then patient may have cognitive symptoms that is like hot flushes, sleep disorders, mood changes, or a slight loss of memory that is also categorized as Alzheimer's disease. In breast, it stimulates the breast of growth tissue. Then skin, it has a fat deposit in skin. In uterus, it has endometrial stimulation, and in vagina is the thickening of vaginal lining and better blood supply to the vaginal tissue. So estrogen loss in menopause has short-term symptoms and long-term symptoms. So in short-term symptoms, there are mood swings, sleep disorders, acute cognitive changes in which patient may feel irritability because of hot flushes. They have sleep disorders. The rest symptoms like hot flushes, urogenital symptoms in which there is atrophy of the genital area. So patient may feel difficulty in maturation, skin changes. They all start, but they do remain for a long term. Cardiovascular changes, osteoporosis, and Alzheimer's disease. Symptoms start and increase from 2 years prior to the final menstruation period. The symptoms vary widely. They vary from patient to patient. In perimenopausal phase, the patient may face menstrual irregularity, or some patients may not face any menstrual irregularity. Hot flushes and sweats are common. The sleep disturbances are there, vaginal dryness, urinary symptoms, mood changes, loss of libido, osteoporosis and CVD, and stroke risk increases in menopausal women. Menopausal symptoms are self-limiting. Usually they last in 2 to 5 years. Hot flushes, we all know it's sudden feeling of heat in the upper part of the body, then spreading to the whole part of the body, followed by palpitation and sweating. It lasts for a few minutes and it's all normal. Then there is sleep disturbance. Disturbance is also because of the hot flushes. Then there are the vaginal symptoms such as the dryness, dyspareunia, recurrent UTI can be there. So there is one more category that is called premature menopause. So premature menopause is defined as normal function of the ovaries before age of 40. So we have two categories, whether the patient is in early menopause or the patient is in the premature menopause. Early menopause Menopause is when patient has a menopause in age between 40 to 45 years of age. That is considered as early menopause. And premature menopause is when patient has a menopause before 40 years of age. So, what there are certain causes for the premature menopause, that are surgically induced menopause. That is when we do a hysterectomy for a patient for a particular reason. It may be radiation induced, chemotherapy induced. It may be linked with smoking, low socioeconomic groups, BMI, or if a patient has a family history of premature menopause, then it is seen that the patient may have a premature menopause. Then it's a primary ovarian failure. In primary ovarian failure, mostly the cause is not found, but in some cases, it is seen that it may be associated with chromosomal abnormalities, autoimmune disease, enzyme deficiencies. So it is rarely found, and 5 to 15% of women with primary ovarian failure may retain intermittent ovarian function for years and spontaneous ovulation. In such cases, pregnancy may or may not occur. So now we'll go to the management part of the menopause. So what all we can do for the management is, first is the reassurance, then the education and the lifestyle changes, then HRT and other alternatives. Other alternative includes home remedies. The governing principle is consideration of HRT should be a part of an overall strategy, including recommendations regarding diet, exercise, smoking cessation of alcohol, then consumption for maintaining of health in peri and postmenopausal women. HRT should not be recommended without a clear indication, like if the patient has a history of stroke, hypertension, these conditions should be ruled out. Postmenopausal HRT should not be a single regime, and it should not be made a standard for every patient. HRT should be individualized and tailored according to the symptom and the need for prevention, as well as personal and family history, results of relevant investigations, and the women preferences and expectations. So the first part is the counseling. Women taking HRT should have at least an annual checkup in which they have to include a physical examination, medical and family history, relevant laboratory test, which may include a pap smear test also, and patient is counseled about the lifestyle modification so that we can prevent or reduce the chronic disease. So, what are the lifestyle changes? For hot flushes and night sweats, patient can have a regular exercise and patient can use cotton light clothes. They can sleep in a cool room and stress management should be done because of hot flushes there is a lot of irritability and patient lands up into stress. So the stress management works there and patient do feel lighter with the hot flushes. To avoid sleep disturbances, patients should avoid a brisk walk or exercise late in the day. They should maintain a regular routine. The mood and anxiety, it all depends. The patient should have adequate sleep, regular exercise, relaxation exercise, cognitive symptoms. The adequate sleep and regular exercise, they all can control the cognitive symptom. If the patient is taking caffeine, alcohol, smoking, that should be stopped. It all helps in the sleep disturbance, hot flushes. So, what are the indications of HRT? Firstly, if we are prescribing HRT to a patient, then there is relief of menopausal symptoms, prevention of osteoporosis, to maintain the quality of life in menopausal years. There are special group of women to whom HRT is prescribed, that is premature ovarian failure, gonadal dystenesis, surgical or radiation menopause. Now we'll be discussing the dosage. The dosage should be titrated to the lowest effective dose. If the patient is responding to a low dose, then we should maintain a low dose HRT. We should not jump to a higher dose for the symptoms. Low doses of HRT that have been used previously may reduce sufficiently and maintain quality life for many women. Benefits of HRT effective. They are effective for treating vasomotor symptoms, urogenital symptoms, like patient have urogenital atrophy, so they may have difficulty in micturition, so that can be treated with HRT. Sleep or mood disorders can be treated. Hot flushes, night sweats can be treated. The HRT do prevent osteoporosis. It reduces the risk of colon cancer. And more importantly, it improves the quality of the life and sexual function in a symptomatic woman. So, which HRT to be given? Say if the patient is hysterectomized and patient has no uterus, then we can go for unopposed estrogen. If patient has a uterus, then there are two groups, that is perimenopausal age group and a postmenopausal age group. So perimenopausal age group is prescribed cyclical combined, that is OCP pills. And in postmenopausal age group, we continuous combined pill is given so that patient should not have a breakthrough or withdrawal bleeding. If the patient only has a urogenital symptom, then we can use local estrogen. Hormone replacement therapy, there are low dose OC pills that can be given in menopause transition that we already discussed in straw staging, that is -2 category and -1 category. Premature ovarian failure. In this, the HRT can be given till the age of the menopause. Then the next category is only estrogen, that is in hysterectomized patient, the patients who have no uterus. The next is combined pill, that is estrogen plus progesterone, that is given in the category the patients with uterus, the patient who had subtotal hysterectomy, then the patient who has a history of endometriosis. Commonly used regimes, then we use conjugated equine estrogen with medroxyprogesterone acetate. The next is CE with norethistron. Then we have a combination with micronized progesterone and dihydrogesterone. They can be used cyclical, sequential, or continuous combined. The best is we use a continuous combined method so that the patient has no withdrawal bleeding with that. Estradiol valerate alone, 2 milligram can be used. It also controls the symptoms. Then the patients with the urogenital symptoms, transdermal estrogen creams can be used. They also decreases the risk of CAV, thrombosis. The vaginal creams, Evolon is commonly found in the market. The patients really feel better with these. Next is the Tibolon. Tibolon is a new drug. It is a steroid molecule. It can also be started, but we start it after 1 year of the menopause. But it is not continued after 60 years of the age. Then we have selective estrogen receptor modulators, raloxifene and bezodoxifene. Then non-oral hormonal therapy, it is indicated in the patients who are at high risk. So high risk includes if the patient has migraine, uncontrolled diabetes, uncontrolled hypertension. In these conditions, we don't give the hormonal therapy to the patients. They are for non-hormonal therapy. So, who should get the HRT? We have already discussed women, all women with the menopausal symptoms have to be given HRT. So, when it is to be prescribed, when the woman is the perimenopausal age group, if she has started with the symptoms of menopause like hot flushes, night sweats, then we can start HRT. And in postmenopausal phase also, we can start the HRT. So the minimal dose which control all the symptoms, it's the combined that we have already discussed, transdermal estradiol, that is Evolon cream, estrogen alone that is Mirena can also be used, and estrogen valerate can also be used. Tibolon also can be used. So for how long HRT is to be taken? It is postmenopausal, 3 to 5 years we can give, not more than 7 years. It is indicated that not more than 7 years we cannot continue the HRT. So the key points for HRT: primary use of any form of HRT is to control menopausal symptoms. HRT should only be prescribed for a short-term relief of menopausal symptoms and prevention of osteoporosis. It is always indicated, the time period for HRT is always 2 to 5 years. HRT should not be prescribed in hope or expectation of any protection against arterial CVD or Alzheimer's disease. Oral and non-oral estrogen have different metabolic profiles, so we have to rule out the risk of thrombosis in all the patients. Combined or single pills, they have different effects on the lipid profile, arterial diseases. There may be increase in breast cancer with the long use of these drugs. So, tibolone is the steroid molecule which has seen if we have to give it for a longer period, it has a very less risk of the breast cancer in the patients. So, the data on HRT associated risk should not be extrapolated to women with premature menopause. In premature menopause, we'll continue the HRT till the age of menopause. The role of HRT, what will it do? It will control the natural menopausal symptoms, premature menopause, surgical menopause, other causes of estrogen deficiency under the age of 50 years, like gonadal dysgenesis. In that conditions also we can do HRT. Menopausal women at significant risk of osteoporotic fracture. Consider always we have to consider contraindications before giving an HRT. So there are different preparations of HRT available in the market. The natural estrogens are available, which is estrogen valerate, CE estrogen. The progesterones are available, like medroxyprogesterone, dihydrogesterone, norethistrone, norgestrone. So what is the initial assessment? The patient should not be hypersensitive to any of these drugs. Especially what thing is to be ruled out is the CVD and history of breast cancer. Not only in the patient, we have to rule out the history of breast cancer in the family also, and we have to take out the history of thrombosis also. So, BP, the body mass index, the blood serum lipid profile should be regularly checked on the intervals. Smoking, alcohol consumption should be stopped. So, we should offer patient the breast examination regularly. Cervical screening via pap smear should be done. Lifestyle advice in which patient has to maintain a proper routine. She should take a regular walk. These things are the lifestyle modification which can help in her menopausal symptom. Then we, if the any of these risks are present, so we have to document these risks and then we have to decide which type of HRT is best for that patient. So there is systemic oral HRT. We have already discussed a cyclical combine that can be used in perimenopausal age group. That is, I already discussed the patient with uterus, that patient that doesn't have a surgical menopause or the patient has not get hysterectomized. So the continuous combine, they can be used more than after 1 year after the last period. And if there is no menstrual bleeding for more than 1 year, if bleeding beyond 3 to 6 months, she need investigation because there can be risk of endometrial hyperplasia or there may be a cervical cause. So if there is a bleeding, patient definitely has to be get ruled out for the other cause. Unopposed estrogen, only if there is no uterus and the Premarin is used. So there are contraindications for the HRT. Breast cancer, endometrial cancer, untreated endometrial hyperplasia, undiagnosed vaginal bleeding, thromboembolic disease, arterial disease, active thrombophlebitis, liver disease where LFTs not return to normal, pregnancy and breastfeeding. So if a patient is going for a surgery also, then we have to stop HRT 4 to 6 weeks prior because with HRT lipid profile really changes. So we have to stop it 4 to 6 weeks prior any surgery. So osteoporosis, it is seen that postmenopausal patients are very vulnerable to osteoporotic fractures. So what is this? HRT is effective in preventing bone loss associated with the menopause and decrease in incidence of osteoporosis related fractures, including vertebral and hip fractures, even in the women at high risk of fracture. The initiation of HRT for the sole purpose of the prevention of fractures after the age of 60 years is also included. Continuation of HRT after the age of 60 years for the sole purpose of the prevention of fractures into account the possible long-term effects of specific dose and method of administration has been proven with non-hormonal therapies also. So if the patient is still considered at the risk of fracture after the cessation of HRT, additional therapy that I'll discuss later on, additional therapy can be given to the patient to prevent osteoporotic fracture. So what are the risks of hormonal therapy? It increases the endometrial stimulation, which leads to endometrial hyperplasia. The patient may lead to endometrial cancer. Venous thrombotic disease. If the HRT is used more than within the 1 to 2 years, then the patient is at more risk. So it's seen that with the long use, the patient may be at the increased risk of breast cancer, ovarian cancer, if therapy is used more than 10 years, cerebrovascular accidents, and lipid metabolism is affected. So, what are the other supplementation to prevent osteoporotic fractures? That is, calcium can be added, vitamin D can be added. The new drug bisphosphonates, they have really shown a good effect on osteoporosis, that is alendronate. Then to sit upright for 1 hour, then zoledronic acid 5 milligram. Then complementary alternative therapy is the herbal therapy that is given to the patient who is not fit for HRT. And the patient who refuses to take HRT, in that patients we can give the herbal therapy. So contraindications I've already discussed. So what are the relative contraindications of HRT? It includes migraine. See, if a patient is taking a HRT and suddenly the patient has more episodes of migraine, then we have to stop this HRT. Thrombophlebitis, family history of cancer, uterine fibroids, endometriosis, gallbladder disease. These all are the relative contraindications in which we have to look out whether we can give patient the HRT or we have to stop it. We have to stop HRT if migraine worsens, if there is a jaundice, as we already discussed, it affects the lipid metabolism. The BP starts increasing or 4 to 6 weeks prior surgery, then we have to stop the HRT. So, what is the maximum duration in for which the HRT can be given? 3 to 5 years is the maximum period, and up to 7 years. But after the age of 60 years, we don't prescribe HRT. So when to stop HRT? The general rule is to stop it after 1 to 2 years to see if the symptoms have gone. If the symptoms reoccur in any patient, we can again start the HRT but with a lower dose. Stop HRT 4 to 6 weeks prior to major surgery. If started for early menopause, then we have to give till the age of menopause. Side effects in first 12 weeks, which are very commonly seen in all the patients: breast tenderness and nipple sensitivity. The nipples may be sore also. The appetite rise and weight gain. Calf cramps are present. So the patient must visit to the doctor 6 months annually, in which the pelvic examination, cervical screening, BP, breast examination, everything is done. So the medical alternatives are also there which can be used. Tibolone, it is a synthetic steroid with weak estrogenic and progesterogenic action. It can be used. Clonidine, it's alpha 2 agonist. Clonidine is basically for the vasomotor symptoms which are there in the menopausal patients. SSRIs are used. So if a patient is having sleep disturbance, night sweats, they can be treated with SSRIs. Gabapentin is also used to reduce the frequency of hot flushes. Progesterones, they do reduce the hot flushes. Then there is clonidine, it's kind of anxiolytic only. Gabapentin, it reduces the severity by 45%. So the natural herbs and remedies which are present to prevent menopausal symptoms are phytoestrogens, that is red clover. It is basically similar to the estradiol, and it is efficacy data is insufficient available in the India. The next is the black cohosh. It is also used for menopausal symptoms, and they are the progesterone creams and the acupuncture. So these are the phytoestrogens. The phytoestrogens are the basically used in the herbal medication. The isoflavones, the flavones, which reduce the symptoms in menopause. Isoflavones can mostly be seen in soyabeans, lentils, chickpeas. Lignans are found in beans, sprouts, sunflower seeds, spinach, clover. And comstans, mostly cereals, fruits, vegetables. So the most effective are the isoflavones. They effect on hot flushes and various consistent. Only there are the with this we have a delayed improvement. So this is the management. if we have a troublesome menopausal symptoms using non-hormonal treatment. So if we have to treat the vasomotor symptoms, we have non-pharmacological treatments. For this, we can offer cognitive behavior therapy, then offer hypnosis if available, consider acupuncture if available. If ineffective, then offer pharmacological treatment. And if we are prescribing patient a pharmacological treatment, so we start with the estrogens. We start with the low dose, and it depends upon the patient. If patient is not showing improvement, then we can give a higher dose. If it is ineffective, then we can do the extended release and then to 75 milligram. Again, if it is ineffective, then we can give paroxetine, that is 10 to 20 milligram. If there still that is ineffective, then we can give gabapentin, that is 100 to 300 milligram. If still the patient does not feel relief with the night sweats, sleep disturbances, then we can give clonidine, that is 0.1 milligram, that is anti-anxiolytic. Then we have to, if patient is still not tolerating these drugs and showing no improvement in the symptoms, then we have to review our pharmacological treatment after 4 weeks if possible. Treatment should be reevaluated every 6 to 12 months. If the patient still is not responding, then what we can do is we can give a combination of pharmacological and non-pharmacological treatment to the patient. If we are managing the vaginal symptoms like vaginal dryness, dyspareunia, then for that we can use a silicone-based lubricants. We can also offer water-based lubricants. Then we can give topical anesthetic that are applied at the vulva. So the hot flushes, substituting soy nuts for non-soy protein in the diet, and they are consumed 3 to 4 times throughout the day. So this is associated with a decrease in hot flushes, and they show improved symptoms also. So medical herbs with the following active ingredients has shown promising results. That is Cinnamon wilfordi, Phlomis ambrosa, Angelica gigas, cinnamic acid, S-methyl ester, Decoresa, and Decoranosol. So these all herbal remedies, they have shown a tremendous result in the postmenopausal symptoms that we can see in the estrogen 100. It is a balanced formula, and with this, patients have less of menopausal symptoms. So these are the studies in which it is shown a natural remedy used for 100 years in both Korea and China has shown significant improvement in the quality of life of women dealing with the symptoms of pre, peri, and postmenopausal age group. There is another study also. Both the studies have shown that the patient has improvement in the quality of life. So we can prescribe, this is a wonderful product which the Shield Connect has given to us, Estrogen 100. It can be given in all the three categories: perimenopause, menopause, and postmenopausal age group. So it improves the this mood swings, insomnia. It improves the bone density so that the patient has less of osteoporotic fractures. It reduces hot flushes, night sweats. It also has a less risk of breast cancer and endometrial cancer because this is a non-hormonal therapy. So no risk of cancer is there with this treatment. So the evidence shows that there was less of vaginal dryness, hot flushes, mood swings, and bone pain. The symptoms are relieved within 7 to 14 days of this non-hormonal therapy. So these are the other studies which have shown that after starting this estrogen 100, there was a significant decrease in osteocalcium. The bone mineral density was significantly increased. There was a decrease in alkaline phosphatase present. So the results are the estrogen 100 was used for 12 weeks, statistically significantly improved the quality of life. 9 different symptoms which are taken in the these hot flushes, night sweats, parenthesis, nervousness, melancholia, vertigo, fatigue, rheumatic pain, vaginal dryness. all these symptoms were present in the categories were improved, and no such adverse effects were reported with estrogen 100. As we know, it is a non-hormonal therapy, so no risk of breast ovarian carcinoma in this, and there's no risk of endometrial hyperplasia also. So thank you very much. I hope my information has given a lot of informative talk to you. Thank you. And thank you that they have chosen such a wonderful topic.
Thank you very much, madam, for this nice presentation. You have covered almost all these things related to the menopause. Just give me 1 minute time, ma'am, to check the questions, if any, in our dashboard. Madam, one question is there, that is how to treat vaginal dryness at times.
Yeah, in vaginal dryness, the topical estrogens, they work very well. There's the Evilon cream, that is estrogen that is available in the market. We can prescribe the patient to take this lubricant, or either if the patient is still not relieved with this, we can advise patient the silicone lubricants, the water lubricants, even the xylocaine jelly can be used for these patients.
Thank you very much, ma'am. And another question is, ma'am, in case of perimenopausal period, what can be used except it's non-estrogen?
Except?
Non-estrogen.
So we can use a combined pill that is the best for perimenopausal age group. So in perimenopausal age group, we don't have to give a continuous treatment like we have to give in the premature ovarian failure. We can give a combined pill, and patient shows a wonderful effect, and we can continue this treatment till the age of menopause, because we have seen the category, the patients are not satisfied if they're not having their regular cycles. So what we advise is, we advise them a combined OCP so that the patient have a regular menstrual cycle, and she's very satisfied with that.
Thank you very much, ma'am. Ma'am, I could not find any other questions. So thank you very much, ma'am, for this nice presentation. Also, I could see appreciation from Dr. Seema, madam. She told that it's a nice presentation in our dashboard. So thank you very much, madam, for your valuable time once again in Shield Connect, and in future also you look forward for some valuable session and interesting session with you. So thank you very much, madam, and have a good day, ma'am.
Thank you.
Thank you very much.
Ma'am. Thank you so much for all the delegates participating also. So kindly do turn to the Shield Connect page. Thank you so much, ma'am.
Thank you, ma'am. Thank you so much.
Yeah, welcome, and thank you so much.